Across Nigeria, many clinics open at dawn and close well past dusk. In many of them, one nurse or one doctor is responsible for the care of the entire community. According to the Nigerian Association of Resident Doctors, Nigeria currently has a doctor-to-patient ratio of 1 to 9,083, compared to the global standard of 1 to 600. Now, the big question remains, how do we build a healthcare system that truly works for everyone and not just a privileged few? Welcome to another episode of the Leading Woman Show Season 4, themed The Nigeria We Want. Brought to you by our partners, the National Endowment for Democracy and Luminate. I'm your host, Abosede Jojagan. In this episode, Reimagining Nigeria's healthcare system, we look into one of our nation's most urgent needs. And joining me are guests who are experts in this field. Please welcome with me Dr. Alero Roberts, a professor of community health with the College of Medicine, University of Lagos, and an honorary consultant to the Lagos University Teaching Hospital. She has been on the front line of health information and education for the Association of Public Health Physicians in Lagos State and has led research on childhood development, early infant and young child nutrition, child survival, and primary health care service delivery. Our next guest is Dr. Ibrahim Banaru Abubakar. He's a consultant family physician with Ahmadu Bello University Teaching Hospital, Zaria, and a passionate advocate for equitable, people-centered healthcare in Nigeria. A fellow of the West African College of Physicians, he anchors health policy dialogues with the Nigeria Economic Summit Group and serves on the board of several impact-driven organizations. Up next, we have Dr. Kemi Da Silva Ibru, a consultant obstetrician and gynecologist and public health physician with over 30 years experience across 3 continents. She's the founder of the Women at Risk International Foundation, WARF, a leading nonprofit organization addressing sexual violence, rape, and human trafficking in Nigeria and across Africa. She also serves as co-chairperson of the UN ACT Global Steering Committee and is a member of Nigeria's Presidential High-Level Advisory Council on the support of women and girls. Finally, please welcome with me Dr. Fatima Zara Modibo, a physician, health tech entrepreneur, and gender equity advocate with over 20 years experience across sub-Saharan Africa and the MENA region. She is co-founder and managing partner at Debo Africa, where she advances women's access to diagnostic services and tech-enabled health solutions. Stay with us. So welcome to all of you. Thank you so much for being here. It's good to have you on the show. Today we're talking about reimagining Nigeria's healthcare system. And I think where I want to start, Dr. Roberts, is what is working when it comes to our current healthcare system? And what, in your opinion, is fundamentally broken?
What is working is that we have every policy that you can possibly think of, and we've signed up to quite a few of them at global level. What is fundamentally broken is very simple: trust. The trust of the common man, woman, and child in the health systems that we have is fundamentally broken, and that's what we really need to work on.
I would love to hear from you, Dr. Da Silva Ibru. What do you think is broken and what is working?
I think I'm going to echo what Professor Roberts said. Fundamentally, we live in an environment where we've identified our needs. A lot of time we go into the weeds and then we unpack, these needs based on the different health sectors. Like I look at myself in sexual reproductive health and I say, well, my focus is gender-based violence. So I'm trying to unpack, well, how do we address a problem of such staggering numbers? A problem that has challenges because of the social drivers that we see every day. Either it's a patriarchy that Professor Robert and I were talking about earlier, or traditional practices, or just a culture of shaming and blaming. So again, in the broad strokes, we recognize these things, but we spend less time collectively and in a sort of sectoral approach addressing these issues. We work in silos, don't we? We're constantly reinventing the wheel as we move from either one sector to the other, or even from one state to the other.
Fabulous. Thank you so much, Dr. Banner. What would you say to that?
If you ask me what's working, I would say that there are resilient healthcare workers. There are doctors that are overstretching themselves. There are nurses that are working overtime, sometimes drawing out of their pockets to pay for patients. There are, healthcare workers that trek miles to give immunization. That is what is working currently. They're overstretched team, but they're still working. And if I'm asked what is not working, I will say that we are not funding the health sector.
Dr. Zara, what would you add?
So, it's interesting because as they were speaking about what is working, yes, we do have the policies, and we're very good at setting up committees to write those policies. We're very good at traveling globally to see what is working and coming back to say we're implementing. But is it actually working if we have the policies, but the policies are not put to action? He's talked about the health workers, and I'm sure we'll go into that. They're overstretched. I agree that we have those policies. The policies are not put to action. We're in such a fragmented place right now. We are not collaborating enough across sectors. We're not collaborating enough as healthcare workers. The trust is broken, and rightly so. The primary healthcare needs to work for this to really, get to the crux of it.
Thank you so much for that. Now, Dr. Roberts, I want to go to the social determinants of health, because from everything that I've heard, maybe we should be working more towards prevention, for example, and not maybe wait till we have to focus and be heavy on treatment, right? So many people don't know that there are other things that impact on how healthy we are as a people within the nation. Can you talk a little bit about the social or environmental determinants of health?
I was actually dreading that question. I usually give a 3-hour lecture to medical students on that question, and I think
we would need a 2-minute summary, please. Thank you.
Where do I even start? Dr. Da Silva, help me out here. Dr. Ubedibo. When we are looking at the social determinants for health, we're looking at every single thing you can think about, from the way you think, what you eat. Where do we begin to start? So something has come to my attention, well, not recently, but pretty recently. And it is this issue of betting and gambling. It just sort of occurred to me about a year or so ago. What are we doing with our youth? What are we doing with each other? And you think about it and you realize that talking to one or two people, this is by no means a qualitative study, as my public health professionals, but talking to one or two people and trying to understand that attitude that causes people to get into what I would call destructive behavior. And one of the things that what really struck me was that they know that this behavior is destructive. But they need to eat, they need to live, they need affirmation from their peers, they need to see and be seen. So, we can sit down and start listing all the social determinants, we've all got the textbooks on them and whatever, but it doesn't really help the situation when you actually talk to people and say, okay, what is driving you to do something that is going to be inimical to your health outcome? One of the saddest things I ever heard was that, what future do I have? And this is a young person, under 30, and he doesn't see himself as being here on earth in the next 10 years. So why not make the best of the little time I have left, do what I have to do, and he doesn't see a future for himself.
Wow. So, Dr. Da Silva, I want to come to you. What urgent things do we need to do to build a more equitable and efficient healthcare system?
Well,
Zara talked about the fact that we travel and go and do the learning.
Right.
And then we come back and nothing changes.
Well, urgent implies one or two things. The truth is we have a laundry list of urgent needs. Recently, I read that for every one physician in Nigeria, there's an average of 19,000 patients that they're expected to see. So clearly, no matter how great that physician is or how hardworking that physician is, that is a number that can never be met and a need that cannot be met. We need to create a national reform to encourage and increase capacity. We need to improve work conditions so these young physicians remain in this country and continue to do the work. We need to be collective in that regard. And then when we talk about health financing, and all of us here I'm sure will agree, this out-of-pocket approach that we continuously adopt when it comes to funding health is not working either. What we need is a functioning health insurance system. This is not reinventing the wheel. This is a tried and tested option that we've seen work in other parts of the world. We spend so much time and energy having those conversations. And yes, we have really fancy, policies and booklets that all of us can attest to. So let's start there. Let's start unpacking these big but obvious concerns with solutions that actually work. Then we can start to address all the other aspects, the capacity building, the monitoring and evaluation. How do we talk about systems on innovative change if we have an environment that's not enabling? We need to take a step back and realize that we can't keep doing the same thing and expect a different outcome.
I absolutely agree with you. And I mean, that really is a nice segue, Dr. Modibo, into women's health. I want to sort of circle in on that and talk about, the needs, the unique and peculiar needs of women. I mean, we're talking of all these big issues, and some people might think, excuse me, why are you now segmenting? But can you speak a little bit about why that is important, whether it's our sexual and reproductive health needs or just the needs of women generally? I mean, family planning tends to be very controversial, for example. So if you can speak to some of these things.
Women are the bedrock of our society. We take care of everyone and we leave ourselves last because you need to take care of the husband and the mother and the child. Women are unique in their makeup. There are many conditions such as fibroids, endometriosis, that go years without being diagnosed. They often feel unheard, unseen, often dismissed. It takes about a year from when a woman feels a lump in her breast to when she gets to the right specialist. Multiple dismissals and referrals, that's when she even gets to go, because as I think Professor Roberts or Dr. Da Silva said, before they go, they need permission sometimes, right? Before they even get to the point of getting to the hospital. Then there's the issue of financing. Many women are not self-sufficient, so they need somebody to pay for them, right? So it takes a year, and by the time they come, we're often left to say, you've come too late. There's, sexual violence, there's domestic abuse, apart from the other things that happen with perimenopause and menopause, so very unique. And when you don't have people that understand some of these issues, they kind of dismiss it and say it's probably stress. And you have women going back and coming back and being treated for malaria and typhoid when it was ovarian cancer. 1 in every 4 now we're leading to statistics on breast cancer, And in Africa, it comes really aggressive because of our genetic makeup. So it's something that we need to put at the forefront, because women, again, when we lose a mother, we've lost a generation, because then we have kids on the street, we have more orphans, women are the bedrock of the society, as I said. So I think women's health is one of the most critical factors that we need to solve, and the statistics, as I said, tells us everything.
Thank you for sharing that. Dr. Banner, Dr. Banner, I wonder how you feel hearing that, right? And so we've talked about having the policies. We've talked about, you know, sometimes going to get the learnings. We've talked about some of the challenges. But why are we still struggling with even basic primary healthcare provision?
That's quite an important question, and I will look at it in some 2 to 3 perspectives. One, still looking at social determinants of health, and then women's health. The National Bureau of Statistics tells us that the face of poverty in Nigeria is a woman that is less educated, that is living in a rural area, somewhere in Bayelsa West Senatorial District or Taraba North in Taraba State. So you can see that such a woman lacks agency, lacks the capacity to pay. Every country that is on the path to achieving universal health coverage has public funding at the forefront. It has to be publicly funded. We cannot charity our way out of this health crisis. Yes, definitely. So it still goes back to getting the right statistics, getting the data correct. We need to begin to put out disaggregated data, even when you beyond gynecological malignancies that she spoke about, even non-communicable diseases. When you look at this gender disparity, women have have more hypertension, more diabetes. The data is there, but we just obscure it as adult hypertension rate. We need to disaggregate it so that we know how to channel the funding correctly. And then funding this primary health care, we need to begin to sound it very out there and very loud to the government that there are certain percentage, a large chunk of the population that do not have the capacity to pay. Somebody is multidimensionally poor, so it means the government has to subsidize for them. The National Health Act of 2014 says give at least 1% of the Consolidated Revenue Fund to fund that basic health care that caters for the primary health care. So as of today, the government is telling us that they are doing the least. So what I want, to get out there is that please increase the funding. We know all, we can speak all the English, but just dip your hand into the Consolidated Revenue Fund, make it 2%, increase the funding pocket.
So, Dr. Roberts, I want to come to you and talk about maternal and child health. This one breaks all our hearts. Why are we winning awards in terms of how poor our maternal and child health is in this country? Can you speak specifically to that?
Perfectly. I mean, there's a reason. We have to be first in something. And this one we are the champions. We're holding the World Trophy every single year for being one of the countries with the highest maternal mortality rates, the highest infant mortality rates. And we can speak about it and speak about it and speak about it. And like she says, Dr. Modibo, go across the world and go and find out where it's working and where it's not working. The issue is that we just don't do it. We have not prioritized, and I'm sorry, I'm going to cause a lot of trouble here. And if you want to come and arrest me, you all know where where I work and where I live. And my hands they fit most sizes of handcuffs. The truth of the matter is the financing. And for that, I'm going to hold the finance minister, the attorney general, the accountant general of the federation, and all the finance people fully accountable. Because while they are busy nitpicking the numbers, oh, we don't have a XYZ percentage spread on this thing, women, children, girls are dying. And, you know, I think a lot of people forget that for every one woman that dies, we're talking, Kemi, get me right on this, 20 to 25 more who are suffering lifelong morbidities.
Correct. And that's right now,
Yes.
maternal mortality rate is 1 in 1,049 for
Yes,
every
it's gone up.
100,000 births.
It's gone up. It's gone up in this.
So it's,
Yes. Oh, that is
Yeah.
is held by Nigeria.
held
So
by
we have to
Nigeria.
win award in something.
that's a true index
That is a
of the
true
well-being
yes,
of any country.
Yes.
The
Yes,
maternal mortality
mortality
rate
rate.
and the neonatal mortality
And I mean,
rate.
Dr. Da Silva, I want to even build on that. What can health institutions do to actually be supportive? And what does that ecosystem even look like?
Well, the first thing I always do is contextualize with numbers, because I don't think we have fully grasped the extent of this problem. We live in a country that we said 220 plus million people. Dr. Zara, you're right, half of us are women. We're a young country, we know that. 64% of us are under the age of 24.
25, yes.
And our median age is only 17. Yet 1 in 4 girls before the age of 18 will encounter at least one violent sexual experience. That's the Nigeria we live in today.
Not the one we want.
The women and girls that I see have endured atrocious acts of violence daily, based simply on the premise that our environmental and social determinants allow them.
Exactly.
We live in a patriarchy. We know that as women and men. We see it played out every day. We have traditional practices, social norms that encourage the violence. We have our communities, all of us included, complicit, because we name and shame. So the environment currently is enabling. And yet we all look back and ask ourselves why. And this happens in an intergenerational cycle. We don't see an end in sight. The statistics we quote both globally, we say 1 in 3 women globally, and in Nigeria, 1 in 4, have not changed. The statistics in Nigeria has been since, 2014. It hasn't changed, in spite of everything that we're attempting to do. We need to recognize that this is a critical crisis that needs to be addressed, because it affects 1 in 4 of half the population that we reside in. So when you ask me that, well, what can we do? How do we assist healthcare institutions? Well, I mean, healthcare institutions currently are burdened with mainstream healthcare challenges. So we need technical expertise. We need organizations like WARIF. We need state governments to recognize that technical expertise is needed to address a niched problem. And this can be easily made available. It's part of just a capacity building. I'm not saying reinvent the wheel. I'm saying get specialists to go into the existing healthcare systems. Primary healthcare systems are a classic example. We have over 30,000 primary healthcare systems across the country. And we know that half of them, I believe 20% of them, are functioning. So what we need to do is revitalize these healthcare systems beyond offering healthcare practices to women and men in their communities, and add on this layer of technical expertise. So this would then be readily made available to these women too.
So I want to start to transition to solutions. I think we've talked a lot about what the healthcare system currently is, but we want to reimagine it. So Dr. Modibo, I want you to tell us a little bit about how technology and innovation could potentially help us and maybe even leapfrog, to address some of these issues.
I actually love the era that we're in, because technology is going to democratize everything for us. And it's not here to replace doctors or scientists or nurses. It's actually here to support these healthcare workers to be more efficient. So when people talk about AI, I talk about AI for good. And AI for good, and healthcare is one of the places where AI can definitely do good. So technology in the way of supporting our health records. Because, we talked about this chaos. We need coordination. So let's move away from chaos into coordination. People get to the hospital faster than their health records. How can we use technology to coordinate the health record system so that wherever you go, the doctor that sees you has your records?
Absolutely.
So that you're not doing multiple tests for the same thing. You go to Prof, she does this test. You go to Dr. Da Silva, she doesn't know that Prof has done this test. She does the same test. How can we aggregate our health records into one space? One. How can we use AI? We're talking about the lack of doctors. Yes, and I really want to bring this point to bear, that people left not because they were not patriots, but they left because we didn't have the scaffolding to hold their brilliance. I have a lot of colleagues that wanted to stay, but they had to leave. I have a neurosurgeon, female, one of the first in West Africa, that has left to be a pediatrician somewhere else. Oh, no. This is what we're talking about, right? But we can use technology to bring them back before we have the infrastructure, because believe me, when we have the infrastructure, they're going to come back. Yeah. But how can we use technology to bridge that gap? Somebody doesn't need to be in the same physical space as a patient, be able to provide the expertise for that patient. And that's some of the things that we're doing at Debo Africa. We're using AI. How can we reduce the burden on the tertiary centers? Why should somebody with malaria still be going to a tertiary hospital to see a consultant that is already overstretched? They can be triaged so that they don't have to get to the hospital. And we can use technology and we can use AI to triage simply by putting in symptoms, not replacing, and being very careful, because we have to also regulate, right? The use of technology.
Yes.
Because if we don't regulate the use of technology, it's then going to become a chaotic situation. And people also need to realize that they can only use AI or technology to support. They cannot replace the human factor, the clinical acumen, the diagnosis. Because if you see, and recently I saw an app where they suggest what is wrong, and they stopped there. And I said to them, you can't, if you take that to the pharmacy, and you say to the patient will just go and say, I have malaria, because it suggested it could be malaria. And for them, they were like, oh, they thought it could be malaria, go to your doctor. I said, no. It could be malaria means go and treat yourself. Yes. Exactly. So we need to be careful on the messaging when we're developing our technology. What messaging, what language are we using, so that people also realize, okay, I have this, I can triage now. I go to the primary health centers. Even the primary health centers, many of them are not equipped enough with clinical staff. We have a lot of community health and volunteers there. How can we leverage technology to provide access? So you walk in there, somebody doesn't have to be physically there, but you can still access the right expertise wherever they are. We're talking about a place where people travel for MRIs, CT scans. Unfortunately, because we don't aggregate using the technology, they can go to one place miles away and be told that MRI is not working.
Exactly.
So why can't we use technology again to aggregate so that when I'm going, I know where
you're
exactly
going.
where I'm going?
Fabulous.
Exactly.
All right. So as we begin to bring this conversation to a close, I want us to really think, how can we redesign our healthcare system? And I want to invite us to give maybe one or two, because as we alluded to earlier, it has to be, if it's urgent things, then it can't be too many things, right? So Dr. Banaru, let me start with you. How do we redesign or reimagine our healthcare system? What are the two key things that we need to do?
Yeah, thank you very much. I'll still go back to the issue of funding because we keep blaming the rural woman that she delivered at home. She did not access care, but is the hospital there? Are the doctors there? Are the midwives there? So and then does she have the capacity to pay? Because we are asking her to pay out of pocket. Today, probably the average cesarean section that you could get might be around 250,000. That's in a general hospital, not in the Lagos setting, of course, in a general hospital somewhere far. And the minimum wage is 70,000. That's like 840 per annum. If somebody spends 250,000, that's catastrophic health expenditure. It pushes them down the poverty line. So what I would say is the low-hanging fruit will be to prioritize the primary health care, where we have promotive, preventive, and curative care, and then to also expand the funding so that those who do not have capacity to pay are catered for. So the goal is not universal health insurance, but universal protection. We need to have that risk protection and say, look, this is the social protection flow. Nobody should go under this flow. That everyone that requires care at the right point in time should be able to access it, and then the lack of capacity to pay should not be a barrier to access. That's what will bring equity. I think I'll stop here.
Thank you very much. Dr. Da Silva.
Well, I think I hear what both Dr. Zara and Dr. Bala are saying, and I agree with you. But I think we still need to layer that with gender-responsive reforms, gender equitable services. We've spoken about that in different aspects today. And I think that is one of the cornerstones in ensuring that we see transformative change in our healthcare system. So let's create that enabling environment for that to be achieved. Thank you.
Very much, Dr. Roberts.
So I'm going to stand very squarely on Dr. Bala's shoulders here. It's going to boil down to the funding, the financing, the funding, the innovative financing strategies, because everything you're speaking about, Dr. Modibo, Dr. Da Silva, boils down to, do we have the money? And you mentioned a very important topic, critical thinking. So being able to train the healthcare workers, we need staff to train the healthcare workers. And we're talking healthcare workers from cleaner to clinician, every single aspect, because a healthcare worker who is in the cleaning services in a hospital is different from, thank you very much, you totally understand. So we need that funding. We need to have that funding in place. We need to have it completely ring-fenced and protected for us to be able to do anything else that we're doing. If we're bringing in AI, we're bringing in gender-responsive policy reforms and implementation, we still need to have the people who are going to carry it out. That resilient workforce, we do need to have that, and that requires funding. I will end with one statement where I had to sign a release form for a new consultant. She just passed the exam 3 weeks prior, and she says, "Ma, we're going off." And I'm like, but why? But why? You know why? Because the airfare for a family of 5 to go to another country, a high-income country, and earn a salary was less than the school fees for 2 of her 3 children in the school that she went to. Can you get your head around that? She says, if I cannot provide my children with the education that I had, what am I doing here?
Thank you very much. So that's a good opportunity for us to take audience questions, and we will do this when we get back. Stay with us.
Thank you so much for this interesting section. I really felt the passion from the guests. So my question is, what can really be done about the doctor-to-patient ratio to prevent fatigue for healthcare workers?
So what can be done about the doctor-to-patient ratio?
I'm going to pull rank here and ask Dr. Bala to take, that is a very key one.
Thank you. That's a very important question, and I think it's coming at a time that currently the resident doctors are on strike. They've been, I think today is the 11th or the 12th day that they've left the hospital, the federal and state tertiary institutions. And there has not been really some conversations around that, even in the mainstream media. I just see a pocket of reports about the strike. That's a critical segment of, the tertiary institution, because, I mean, currently all the teaching hospitals are just operating at skeletal level. So to improve that, the doctor to patient ratio, looking at, it's interesting that the first item on the 19 demands that these resident doctors were, putting to the government, they were saying that our working hours are too long. Please cap our working hours and then increase the number of staffers. So I saw a national policy that was released last year, a national policy on health care workers migration, a very fantastic, document, but there's I didn't see the implementation framework. So it outlines some strategies to, bolster the number of healthcare workers, not just the physicians. So it goes back to what Prof mentioned about education. We have to start with, we've seen proliferation of medical schools, but do we have the teachers at the universities funded to churn out these, medical students so that we have the next generation of clinicians? And are we providing an enabling environment so that we do not continue to see the attrition that we are currently seeing? The statistics are quite high. We're talking about 20,000 healthcare workers leaving, in the last decade. Doctors, not just health workers, 20,000 doctors in the last 1 decade. That's quite a large number. So we need to start from the bottom up, training the medical students, meaning funding the educational sector, the medical education, probably declare a state of emergency and say that, look, we need to produce more healthcare workers. Some countries have done it. Cuba has done it. They just opened up large facilities to train healthcare workers and even in court export them because they have enough. So if we produce more medical students, we'll be able to cater for, allow for that healthy migration, because it's the fundamental rights of the healthcare workers to be able to migrate. But we need to create, it's beyond remuneration. We need to be intentional about the human resource for health. Recently, the head of service of the Federation went to secure some policies at the Federal Executive Council about, recognition and reward, for mainstream public service, remuneration and reward, incentives and, reprimand, So we need to know that, rewards comes before punishment. So we need to mentor these healthcare workers, provide the adequate enabling environment for them. Then they will be able to stay and then we produce more.
Fabulous. We'll take our final question.
How can we ensure that women healthcare gets the attention it clearly needs?
Oh, wow. How do we ensure that women's healthcare, Dr. Da Silva, do you want to take that? That it gets the attention that it actually needs. We've all agreed it needs attention.
Well, I think as with every critical and crucial issue, it starts with a conversation, doesn't it? Yes. But not just any conversation, the right conversation in the right rooms with the right groups of people. I think secondly, beyond the conversation, and that's something we've all acknowledged, we've talked about many policies, many reforms, many committees. How do we move those conversations that have now become ideas into tangible action plans? And then going beyond that, how do we now ensure that they're funded, adequately so, and then they are now adequately implemented? And so it's just making sure that, as with any value proposition chain, that we go through it step by step, and making sure that we don't miss a step, but we get to the end of the journey. We always stop mid-journey, don't we? We always start strong. We always start with the right conversation, the right question, for instance. We always go into action mode when it comes to coalitions and groups. And then we start listing out frameworks and designs. But then what? Where are those tangible action plans? And why aren't they being implemented? I would say, as with that problem that we've all mentioned, the healthcare systems, women's health should not be addressed as a standalone. I think it has to be part of the integral story. I think a lot of times that gender issue always adopts an add-on approach with any focus, as opposed to an understanding that it's an integral part and a thread in every single sector with every single issue. So shouldn't be a women's health issue. It should be a healthcare issue, and this should be not just a building block, but an integral part of it.
I completely agree. Don't you agree as well? Fabulous. It has been another enlightening conversation on today's episode, reimagining a healthcare system that truly works for all Nigerians. These conversations remind us of what's possible and the urgent work needed to make quality healthcare a standard for every Nigerian. I want to say thank you to our guests for their insightful contributions today. Of course, our live audience for their incredible energy, and to our viewers for watching. Don't forget to subscribe to our YouTube channel, follow us on social media, and share your thoughts on today's episodes using the hashtag #TheNigeriaWeWant. I'm Abosede Jojagan, and until the next episode, remember, women's leadership can change everything, everywhere.